Hello, Mark. Thank you so much for accepting the invitation. How are
I'm
you?
well, thank you. You're most welcome.
Well, thank you so much. So, actually, it's funny because there is a 12-hour time zone between France and New Zealand.
Yes.
So, it's 9 a.m. for you and it's 9 p.m. for us.
Bizarre, isn't it?
Very bizarre, yeah. So, Mark, for those of you who don't know you, even though a lot of us already know you because you're such a reference in the field of physiotherapy, can you introduce yourself and tell us about your experience?
Well, um, I'm old, so it's a long time. I graduated from physiotherapy and as a physiotherapist in 1971. So that's 52 years ago, 53 years ago. And only 5 months after I graduated, I went into private practice on my own account. So I've been in continuous private practice, all except for 5 or 4 years from 1971 to the present day. The 5 years where I was not actually in my own practice, I was actually doing my PhD, and I was still seeing patients, of course.
Mhm.
So I'm a clinician. I mean, it's my primary focus in life has been as a clinician.
Yes.
I became aware of science as such, as a sort of an important aspect of things in my 20s, in my early 20s, during the 1970s. And it became very clear to me that we were not taught, as you are today, not taught anything about science and scientific medicine. And
Mhm.
we certainly did not get any training in the scientific method at physiotherapy school. There was no very little in the way of academic resources for reading other than textbooks and listening to people who had strong opinions, basically. So it
Mhm.
was very much a profession, and medicine was too, by the way, very much a profession of uh, eminence based practice versus evidence based practice. I think it's
Mhm.
very important to realize that that's what I grew up with. Okay. And the next 20 years was a gradual exploration of not just science and medicine, but science in general. I actually went back to, I did part-time courses in the scientific, the philosophy of science at the university, and I did extensive reading in epistemology and the scientific method um, during my late 20s and early 30s. So I wasn't just exploring um, physiotherapy and medicine. I was exploring the actual foundations of the method itself. And that,
Mhm.
by the way, that during the time it was rapidly exploring, and I remember very, very clearly the publication of the first systematic review, which was in 1987. All
Mhm.
right. So most people take systematic reviews for granted. We didn't have anybody synthesize the data at all on any subject prior to that time. So
Mhm.
I've lived through that whole process of moving from eminence-based medicine through to evidence-based medicine, and I've been literally a part of it, really, of the growth of that um, new perspective. It's a new perspective.
Yes.
So I was in practice. I was extremely fortunate that in my last year of physiotherapy school, I spent a significant amount of time observing a doctor called Dr. Ian Broadfoot, who was a musculoskeletal specialist, and
Mhm.
he had been trained by James Syriax and by Robert Main in Paris. So he
Mhm.
got his diagnostic methodology from Syriax, and he got his manipulative therapy skills from Robert Main in Paris. and I was 20 years of age observing this guy, and I was instantly attracted to both manual therapy, manipulative therapies, and the actual process of structure and tissue diagnosis before I even
Yeah.
graduated as a physiotherapist. When I went into private practice later that year in 1971, um, I continued. We continued to get together every second week at the hospital in Auckland with Dr. Broadfoot and a small group of other doctors and physiotherapists, where we would talk about cases, talk about manipulation and practice manipulation. And by the time I was 22 years of age, I was a competent manipulative therapist. I didn't have a diploma or anything like that. I just knew how to manipulate every joint in the body, pretty much. Well, no,
Yeah.
in the spine. I didn't have extremity joint manipulation training. I had spinal manipulation training. So I
Okay.
was quite comfortable with manipulating necks and thoracic spines and lumbar spines and sacroiliac joints and what I thought were sacroiliac joints and all those sorts of things. Then at that time, around about 1971, was the time when the New Zealand Manipulative Therapists Association was being formed, and the two instructors for that course were Robin McKenzie and Brian Mulligan.
Mm.
So I,
Wow,
yeah,
what a duo.
and the rules underlying your ability to start that diploma was that you had to be in practice for 2 years. Well, of course, I hadn't been in practice for 2 years, so I wasn't allowed to even begin the formal
Oh,
training
right.
because the rules didn't allow it. I was too young and I hadn't been in practice long enough. And McKenzie at the time was the president of the New Zealand Manipulative Therapists Association who was running this course. So, to cut a long story short, my first formally training, by a manual therapist was from Brian Mulligan on the extremities, and he was teaching the
Interesting.
Carlton-born Evian system. That's the Nordic system, and that was very good, good training. We learned lots of different techniques and lots of different concepts about how to improve range of motion. I rapidly learned that the convex concave rule, which was the foundation of the whole Nordic system, was great in theory, but not so flash in practice. All those
Okay.
all those stiff shoulders from frozen shoulders, I thought, oh great, I've got a technique to fix those. And when I did all the tractions and the glidings and all those things that we were taught to do, it doesn't bloody well work. It didn't work.
Yeah.
So I
No,
quickly I
no, no, indeed.
quickly learned the limitations of those approaches.
Oh, I see.
Even
Yeah.
yeah, so that was important. And then a year later, I started the spinal section of the course, which was run by McKenzie, and he also was teaching
Mm.
the Carlton-born Evian system. Most people don't realise that Robert McKenzie was first before he taught his own material. He was actually a teacher for the Nordic system, and he was very good. He was a very good manual therapist. But
Mm.
he didn't have to teach me manipulation because I was already skilled at that. By the time I started that in 1974, I think it was 1974,
Mm.
I was already able to do any manipulation that we were taught. So that was
What was it like to what was it like to meet Mulligan and Mackenzie? How were they like?
oh, they're very large life people. I mean, they were. I mean, Mackenzie was um, simultaneously imperious. Like a very very self confident. He knew where
Yeah.
he was coming from. He knew what he knew. He knew what he didn't know, and he did not suffer fools gladly at all. If
Mhm.
you asked a stupid question, he'd say that is a dumb question, and he'd give you reasons why it's dumb. You know, he was a
Okay.
very good teacher, actually
Yeah.
an outstanding teacher. He was an even better clinician. He was, and so there's no question about that. Mulligan was Brian Mulligan was an outstanding teacher, all right, but
Mhm.
he was a completely different personality. He was a a joker. He was constantly telling jokes and, doing a miracle every day. That went way back into the 70s. I mean, I don't know whether you've done a Mulligan course, but the miracle every day was, you're going to make somebody cure somebody today type of thing. I mean, he was a showman, absolute showman. McKenzie was not a showman, not like that. McKenzie was
Okay.
a person who would see patients in the clinic and see patients on courses. Mulligan never really did see a lot of patients on courses. He would treat people who are attending his courses, but they didn't bring in patients to the
I
course.
see.
McKenzie
Okay.
always wanted that because in his
Mm.
mind, there's
Yeah.
no point in teaching something you don't do in practice.
Mm-hmm.
And so I
True.
was very much attracted to that very highly practical and pragmatic approach that McKenzie had. In the last year of my diploma in manipulative therapy course in '76, um, McKenzie started to introduce his own concepts. And
Mm-hmm.
there was no book, there was nothing written, it was
Yeah.
just in his head. And I
Mm-hmm.
remember him putting up on the blackboard posture, dysfunction, derangement, and how his story about how meeting Mr. Smith, and he found that this rather not very bright man lay face down on a bed that was bent up and an extension, and how the leg pain centralized and he felt better almost immediately. And that was like a revelation to him that something so simple could be so effective type of thing. And so,
Yeah, there's the story of, sorry, the patient that was left on the table
do you not know about
in
that?
extension. I do. Yeah, yeah, yeah.
Okay, that story. He was telling that story in the middle 1970s. That's
Yeah.
not that's not something that's I mean, he don't. I asked him. I says, "Was his name really Mr. Smith?" He says, "I have no idea."
Smith is a common name.
Or whatever,
It's
I mean,
easy. Yeah.
yeah. Anyway, and I in my 1976, having learned all these manipulations and listened and watched and worked with Brian and Robin in the class, I decided I needed to go down to spend time with McKenzie in his clinic. So
Mhm.
I attended his clinic for a whole week, and I watched him in his clinic for a week in Wellington because I live in Auckland at the time, and he was in Wellington.
Yeah, he's from New Zealand like you.
Oh yes, Mulligan's also a New
Yeah.
Zealander.
Oh, yeah. Only the best from New Zealand.
Well, no, that's not true. But we had a
I'm joking.
disproportionate number of significant people in our profession came from
Absolutely,
New
yeah.
Zealand, but
Yeah.
there are plenty of other people around the world. But
Mm.
some of those were New Zealanders who had emigrated.
Mhm.
Stanley Paris, for example, who was the person who started the whole manual therapy world and physiotherapy in the United States.
Yeah.
He's actually a New Zealander.
All right.
Yeah. Anyway, so he was the first. He was the first president of the International Federation of Manipulative Therapists, Stanley Paris,
Oh,
and he was a New Zealander from Dunedin. Mm. I know Stanley, by the
interesting.
way. And by the way, I've just spoken with him only very recently. He's still alive. Anyway, and so is Brian Mulligan, by the way.
All
Yeah,
right. Yeah.
I last spoke with Brian. I think 2 years ago.
All right.
He's
Okay.
he's in a
Mhm.
retirement home, but he's still, um, alive and well. I mean, he's fine. He's just old. Anyway, so then I went and watched McKenzie for a week, and then I was expecting to see all these manipulations that we had been practicing and he'd been teaching, and he didn't do much of it at all. He was just getting people to do these dumb exercises. And I was actually really disappointed for the first day. I thought, I've closed down my whole practice, and
Mm.
it's costing me a fortune to be here. And all he's doing is giving these people bloody press ups and pulling their knees to the chest and stuff like that. And I didn't get it. I didn't get it. Didn't get
Mm.
it at all. I was a manipulative therapist. And
I see.
and
Yeah.
then on Tuesday, the patients were coming back the next day, and and patients were changing. And by Wednesday, I'm going, oh my God, some of these patients are really getting better very, very quickly. And by Thursday, I thought, holy shit, I should be here a month. And by Friday, I was convinced.
Patients would come in every single
Every day.
day? Every day for how long?
Oh, well, as long as it was necessary. But the number,
Yeah.
you have to realize you cannot extract a person out of their time and look at them and say, and do judgments about. He
Yeah.
was a man of his era, as was McKenzie, Mulligan, as was all of our physiotherapy colleagues. When I first went into private practice, when I took over, I bought an existing practice
Mhm.
with a big loan, I have to tell you. I didn't have any money.
Yeah.
But that he was one of the best physiotherapists in New Zealand at the time. His name was Leonard Ring. You won't know who he is.
Mhm. No.
But the standard model was that the patients were all referred by doctors. We were not allowed to see patients off the street. And the
Oh.
prescription was for daily shortwave diathermy and massage for 6 weeks. And that's what people got.
That reminds me a little bit of a prescription we get in France from doctors.
Well, that was the thing McKenzie and Mulligan attempted to change. There were other
Mm.
teachers, by the way, too. We had about 5 or 6 top manual therapists in New Zealand. You've got to remember that at that time there was no more than about 1,500 physiotherapists, and we had maybe 10 or 15 world-class physiotherapists.
Mhm.
And they formed the Manipulative Therapists Association in order to upskill our whole profession. Brian Mulligan and Robin McKenzie taught for 7 years, and all they asked for was to be given their travel expenses and their hotel expenses. And they traveled the length and breadth of New Zealand and taught for free
Wow.
for 7 years. And there was an intentional gift to our profession, to upskill our
Yeah.
profession.
Absolutely.
Most people don't realize just the effort that went into changing how we did things by some of these
Yeah.
key people. And Stanley Paris, although he don't think he did anything for free, he put in a fantastic amount of time and effort in the United States. Just a huge amount of time, and there were other people too. Jeffrey Maitland was the same. In Australia, I mean, he was an extraordinarily influential person, as you know, and people like Freddie Kaltenborn and Olaf Evianth and people like that. They travelled the length and breadth of the world, everywhere in the world, to teach, just to upskill our profession. So our profession owes these manual therapists a
Yeah.
huge debt, and I
Mhm.
was one of the early recipients of that gift. That there was a sort of a, I don't know, there was a philosophy, if you like, a culture in our
Yeah.
profession that we give back
Mhm.
to our
That's right.
profession.
Yeah.
Anyway, I started after watching McKenzie. I started modifying my treatment for the spine based upon his ideas, and I was meeting him on a regular basis. I'd call him probably every week, and we'd talk for an hour on the phone, which was very expensive at that time. And we just and I would assist him when he was teaching at conferences all over New Zealand. And by the early 1980s, the McKenzie Institute was starting to form. He started teaching internationally in 1976, the same year that I graduated with my
Okay.
diploma in manipulative therapy. And he stopped teaching that year. I was in the last class he taught manual therapy to. And he started teaching his own material internationally. And as
Mhm.
you know, he was a very, very prolific teacher for probably
Yes.
15 years. And to cut a long story short, the McKenzie Institute was formed. I was one of their primary initial teachers. along with a bunch of Americans, one or two people from Europe, and one or two from Australia, but mostly from New Zealand. And I started traveling to teach the McKenzie method in 1985.
Mm-hmm.
What happened in 1984, we had we got all the American physiotherapists who wanted to teach McKenzie to come out to New Zealand to be trained by the New Zealand manipulative therapists to also do to do manual therapy, because most of them were not manual therapists, but New Zealand McKenzie instructors were. We were all manual
Mm-hmm.
therapists,
Yeah.
and so to us there was no conflict between manipulative therapies or manual therapies and McKenzie. It was but the difference was that McKenzie saw manipulation as a graduated endpoint of loading
That's right.
joints
Yeah.
and structures.
Yes. Mm-hmm.
Whereas the manual therapist went straight into there. McKenzie says no. I mean, most people don't realize, but McKenzie was the inventor of
Mm-hmm.
self-treatment as a discipline, as a concept. He invented that
Mm-hmm.
whole thing.
Yeah.
Mulligan and the Nordic people and Stanley Paris and all those people in the United States and Canada, they whatever self-treatment they did was basically borrowed from McKenzie.
I see. I was actually about to ask you the question: how different, in your eyes, are the Mulligan techniques and the McKenzie techniques? Are they complementary?
Well,
How different are they?
I was thoroughly trained in the Mulligan system as well. I mean, obviously, not just in
Yeah.
he taught his own techniques as well as the Nordic system. And I went and did. I helped Brian Mulligan as an instructor right up until the mid 1980s.
Mm-hmm.
And so he was teaching his own stuff then, the nags and snags and all those PRPs and all those
Yeah.
things that he did. And but I was never a Mulligan instructor
Mm-hmm.
because by then I was convinced that the patient ought to do as much as they can for themselves. As
Yeah.
to me, McKenzie had, I'm using modern words now, but McKenzie's idea was the beginnings of the application of cognitive behavioral therapy to manual therapy, to musculoskeletal diagnosis and treatment. Get the patient, self-efficacy was a word that McKenzie and the faculty of McKenzie introduced to physiotherapy.
Mm.
And the whole idea that it's the old story, you give a man a fish, you'll feed him for a day, but you give a man teach him how to use a fishing rod, and you'll feed him for the rest of his life. That was the
Yeah.
principle behind the McKenzie approach, and that began with him. And by the way, I still practice very, very similarly now.
Mm-hmm.
And it doesn't matter. I don't. There are many things about what the McKenzie Institute are teaching now that I actually disagree with, but that doesn't matter. The contribution that McKenzie has made to our profession is immeasurable, immeasurable.
Mm-hmm.
Mulligan and these other manual therapy teachers have taught us many, many useful techniques and procedures. They have encouraged diagnostics, and they have done lots of things like that, which are very, very good. But in terms of fundamentals, I think McKenzie has done more.
Mm-hmm. Okay.
So
Got it.
anyway,
Mm-hmm.
I continued to practice until I had two large clinics in Auckland. One was a specialised from 1991 through to 1998. I opened up the first special spine care clinic in Auckland. And the reason was because I was seeing far too many really difficult patients, and the funding model for that by the government was just not enough to pay for the amount of time that I needed to spend with people, because they were I was seeing all these complex backs and necks. And
Mhm.
so we set up a special spine care clinic. So we had a different funding model, and we didn't call it a physiotherapy clinic. It was just a spine care clinic. And
Sorry, when you say funding, do you get money from the government,
yes,
the social security
well,
system?
it's a quasi autonomous non-government organization called Accident Compensation. And so
Okay.
that came into being in 1974 and is still there today. It's a state monopoly on insurance for people who have accidents, and
Okay, only for people with
that
accidents.
dominates the funding of physiotherapy in New Zealand.
I see. But people with chronic lower back pain, do they get
Oh
any
yeah, they get
refund?
plenty of they have access to care, but we won't
Okay.
go into that. That's a mess. It's
Okay.
not something you want to know about, honestly.
All
Yeah,
right.
it's
Maybe some other
it's
time.
it's it is it's been both a blessing and a disaster.
I
It's
see.
like the national health system in the United Kingdom. The Brits do not want to get rid of it, but whether they how they'll never get rid of their waiting lists.
Yeah, true.
You can't choose your doctor,
Yeah.
you know. So I mean, there are many things wrong with the NHS, but the Brits will never get rid of it. We have exactly the
Hmm.
same conflict here in New Zealand with accident compensation. There are many things wrong
Hmm.
with it. Really bad, really, really bad. It's not good for our profession in the last 20 years. But it actually funded the growth of physiotherapy in New Zealand in the 70s and 80s. Yeah.
Okay.
But that's another story. That's politics. Let's not go there.
Yeah. Yeah, let's put it aside for now.
Absolutely. Anyway, so anyway, I in 2001 I sold my clinics in Auckland and my nice big house, and I self-funded my own PhD. I had been invited to do a PhD out of a university in Sweden, and Professor Birgitta Oberg, who was generously asked me to come and do a PhD with her. Um, and the reason why she asked me is because I'd already done the sacroiliac joint studies with Dr. April in New Orleans. And while I was teaching in Linköping in Sweden, I was teaching there, and she was sponsoring my courses. I was teaching the spinal courses, the McKenzie courses, and my own upper and lower extremity joint courses in
Hmm.
Sweden. And I said to her, "Look, I've done the sacroiliac joint study. Now I want to spend more time with Dr. April and do more studies on the facet joints and on discs and stuff like that." And she said, "Well, if you're going to do that, you might as well do a PhD, and you can come to Sweden to do it." And I didn't go to Sweden. I didn't live there. I sold my practices. I moved into a house I had bought and owned. My wife and I, our children were all grown up. We moved into a 4-bedroom flat, and I did my PhD doing my research in New Orleans, traveling, going around the world about 3 times a year to the United States to do
Wow.
the research, then go to Linköping in Sweden and to do the academic work, and then back to New Zealand to see my wife, and then back for 4 years. And
Wow.
well, only for two
Impressive.
years mostly. But I continued once I'd finished gathering data. Then, of course, most of the work was academic, and I was not seeing a lot of patients at that time. I was just working on my data analysis and preparing papers and that sort of thing. And then when I finished my PhD in 2005, I didn't want to own any practice anymore. I'd done that for 30 years. And I got invited to come down here to Christchurch to work with a guy called Graham Nuttridge, who was also McKenzie faculty. And he agreed to pay me a salary, and I'd teach his staff and continue to see patients. And I was able to go and teach wherever I wanted to in the world and have time off. It was very, very flexible. And so I've been down here ever since. We have, for 20 years, we worked on our registration authority here in New Zealand to get specialist physiotherapists recognized as specialists. And we
Yes.
finally
Yeah.
achieved that in 2019. That's only 4 years ago. Um, and
Wow.
I was already about to retire. I was 69. I'm 74 now. I'm 74 in a couple of days. You know,
Oh,
yeah. So I was 69 when we finally got recognised as specialists, and I was the first one to be registered as a clinical specialist and paid the same by accident compensation as other specialists, medical specialists. So I
okay.
decided to go back
Mhm.
into private practice so that I could end my career actually being paid for the work that I did.
I
So
see.
I've been
Mhm.
back in practice since 2019 as a clinical specialist.
Wow, what an impressive career.
Well, it's long. I mean, you quickly go over that, and it sounds so brief, but it's not. It's been a long journey.
Yes.
Yeah.
Very, very long, but very interesting as well.
Oh, it's been fascinating. It's been a great ride.
Yeah.
It's been a great
Yeah.
journey.
So
I'm
do you work by
retiring from
yourself?
clinical practice this year.
You what? Sorry?
I will retire from clinical practice this year.
Oh, will you?
Yeah.
Okay. Will you continue to teach?
Oh, yes. And
Yeah.
I'll spend more time on research. I've still got a lot of research projects I want to work on. Hmm.
Mhm.
So, oh yes, I'll still.
Are your research yeah, research on lower back pain mostly?
Yes, I did my PhD on low back pain, and so really,
Yeah.
although I feel very comfortable with any part of the musculoskeletal system, back pain is the biggest problem, and spinal
Yes.
pain is the biggest problem, and I'm not happy with how academia is treating back pain from a scientific perspective. I'm not happy with it at all. The concept of non-specific, you've watched my free video. The concept of
Mhm.
non-specific back pain, it's a joke. It's an academic joke.
Mhm.
You don't talk about non-specific chest pain or non or
Yes.
non-specific head pain. Why do we talk about non-specific back pain?
So what would you like to change then in academia to make it
Well, what we
more
have to do is
efficient?
to recognize the science. The science is very, very clear on back pain. It doesn't matter what you do, whether you are a manipulative therapist, a cognitive behavioral therapist, or you're doing CFT, or if you're doing movement analysis and all that stuff, manipulative therapies, acupuncture, prayer, nothing, pills,
Mhm.
injections, nothing is
Mhm.
any better than anything else. That is the fact,
Mhm.
right? We knew this in 1999, 24 years ago, 3 years ago. We knew this. Moritz von Tilda wrote a book. It's right. It's in a box right there. He wrote a book
Mhm.
doing one of the early analyses, systematic reviews of all the randomized controlled trials on low back pain at that time, and it's quoted in that lecture. All right, is that there is no difference between the treatments. Now, what that means, it's very simple. What it means is that either back pain is imaginary, doesn't it's
Yes.
not a real thing,
Mhm.
or it is so many things that any given treatment can't possibly be effective on all of them. Now, which do you think it
Mm.
is? Huh? I mean, seriously, do you think it's an imaginary disease that people are imagining their back pain? No. If you
No.
think that, then you need to go back to school. I
Yes.
mean, you need to learn. You need to get off your postmodernist nonsense,
Yeah.
and actually get scientific. The fact is that
Yeah.
these patients come in having 40 years of age, never having had back pain ever in their lives before, living a full and natural, happy,
Mhm.
productive, and effective, active life, and suddenly they're crippled by back pain. Why? It's something is going on the back somewhere, and it's producing nociception, which will be variously interpreted by your brain and spinal cord as the experience of pain. And
Yeah.
and disability is a consequence of that. It's not. Disability is an effect. It's not actually a fundamental cause of anything. It's a consequence. All right, and pain is your experience of nociception, your conscious experience of nociception. All right, this
Mhm.
is not rocket science. This is very, very simple stuff. You know,
Mhm.
I mean, you get people who make pain so bloody complex. You see these diagrams with a million things on them. Who can ever understand that?
Mhm.
So even the
Mm.
people who write it don't even understand it.
Yeah.
All right, it's far too complex. It's not that difficult. It's in principle, back pain is a consequence, or back related pain is a consequence of something going on inside. Now, you know, and you know what my history probably as well as anybody, that I have a fascination for finding out where the nociception comes from.
Mhm.
I've had that fascination since I was 20.
Mhm.
So, I'm a leopard whose spots have never changed. But I am dealing with people, with individual patients. I don't treat populations, I treat individuals. Now,
Yeah.
one of the big mistakes of academia began in the 1980s, where they started to say, well, in the 1980s, this is before MRI, before diagnostic methodologies were even well established. They realized that a patient can come into the clinic and see 4 different doctors and get 4 different diagnoses. That was the Quebec Task Force on Activity-Related Disorders, published in Spine, Volume 12, 7S, 1987.
Yeah.
All right, that
Mhm.
was the first systematic review on back pain. And they didn't have the electronic services like we have today. They did this all by hand. All right. And they did this massive finding, and they found basically that, first of all, diagnosis is not reliable. Okay. Doctors can't agree with each other on the same patient.
Yeah.
All right. And so they said, well, okay, we have to take a different approach. And the different approach was, so what's the real problem here? Well, the real problem is that although most patients do improve and get better, a significant minority go on to have ongoing pain and disability. And low back pain was acknowledged as being the single greatest cause of disability in the modern world. Pain and disability. I think it was the second most, back then in the 80s, we knew there was the second most common symptom presenting to doctors, second only to headache. All right, so we knew it was a big problem back in the 1980s. And the cost of it was it was already doing this. And it hasn't
Yeah. Yeah.
stopped. It's
Yeah. It
still
hasn't
doing
stopped.
that.
Yeah.
So
Absolutely.
all these changes that we've made haven't made any difference at all to the big problem, at all. So we're obviously doing something wrong. We haven't
Mhm.
affected this trajectory of increasing cost and disability at all. Not at all. So what has happened since the 1980s? Well, first of all, they first started off by looking at what are the predictors of chronicity?
Mhm.
And they did the research. A lot of people from Scandinavia and Europe did a lot of research, and also in the United States and Australasia. And they found that the only predictors of a poor outcome were psychosocial. So all the work except for a very small amount, 90% of the research then shifted dramatically away from pathoanatomy into the psychosocial.
Mhm.
And that's been going on all through the 1990s, all through the 2000s, and now 30 years later, there's still the majority of research has been done is all on psychosocial stuff. You know, they invented the word biopsychosocial, right?
Yeah. Yeah.
Okay. And this is not new. That was in the early 1990s. We all embraced it, every one of us. All right, but we had no doubt that there was a bio. The psychosocial is what influences recovery. It isn't the
Yes.
cause of pain.
Yes.
Okay,
Absolutely.
there is a cause of nociception that is being affected by the psychosocial things that results in persistent pain and disability. And now, those of you people who have been trained only in the psychosocial and very little in the bio, okay, think that you can suddenly make pain happen spontaneously out of nowhere. That does happen, but that's a psychosis. It's not routine back pain.
Yeah.
Just because you've got a rubber hand and you hit a rubber hand and somebody goes ow, that doesn't mean you can create non-existent pain out of nowhere. That's a,
Mm-hmm.
that's a trick. That's a
Mm-hmm.
trick. It's nothing more than a trick.
Mm-hmm.
It's like, you get a potato and you put a straw against it. If you push it in, you break the straw. But if you go bang, you can drive that straw straight through the potato. It's a trick.
Mm-hmm. Yeah. Yeah.
It's a game. You don't fix a nociceptive source of nociception by fiddling with the mind and fiddling with behavior.
Yeah.
It doesn't work. And what's more, if it did work, you would be starting to see some change in the trajectory of increasing disability and pain in society. We're not seeing that. We've been desperately trying to do this for 30 years. It's not working.
So, as physiotherapists, where do we stand?
Well, no. We stand exactly where we stood all through this time, is that we have to understand the science. The science
Yeah.
is being dominated by statisticians who believe that the only way that we can manage back pain is by influencing risk factors and epidemiological issues. So, in other words, we know that you're at risk if you don't like your boss at work, or if you're unhappy at home, or if you are depressed, and or there's a welfare state that's picking you up and giving you the opportunity to have lots of time off work for no cost to yourself. All right.
Mm-hmm.
We have all these psychosocial economic things which are the driver of the increasing costs. All right. Now, so what we've got to do now is, if our focus is to try and manipulate people's behaviors and their beliefs about pain and their cognitive errors and all these things, which are all true. I mean, these are real things, but it doesn't fix the back pain. The only small little thing that might have shown that this approach to back pain actually is successful is Peter Sullivan's cognitive functional therapy. He has shown that that you can actually make a pain to change pain as well as disability, but it's not big. It's small, and only on the most chronic people. Now, the vast majority of back pains we see are not people who have had pain for 10 years. The vast majority of
Yeah.
people have had pain for less than 3 months or 6 months.
Yeah.
So it doesn't apply. You can't take a bunch of people who have had chronic pain for years and years and years and are chronically off work and say, look, we do this cognitive functional therapy thing and we get a good result. And it is a good result. I'm not disputing that at all. All right. And then apply that to the person who walks in with their first episode of back pain. It doesn't work.
Mm-hmm.
We have to be absolutely frank and honest. And I've had this discussion with Peter. Peter's a good bloke. I like Peter, and he's a very, very impressive presenter.
Peter, can you
Peter
repeat his name?
O'Sullivan.
Oh yes, O'Sullivan.
Cognitive functional therapy. That's his word. That's his change from cognitive behavioural therapy.
Yeah.
He's made it a physiotherapy thing instead of a psychological thing, which I think is appropriate, by the way, and certainly is a good system for people who are in pain clinics, for patients who are presenting to pain clinics. But for the average
Mm-hmm.
physiotherapist out there, you don't just being functional in the way that he does it, I don't believe is actually that successful.
Okay.
That's my personal belief. And Peter may well argue differently, and that's fine. And I'd be delighted to always have a conversation with Peter. He's a good bloke. So here's the thing: we know that back pain can be caused by a multitude of different things. All right, that the actual origin of nociception can be the disc, the facet, the sacroiliac joint. It can be nerve root involvement and things like spondylolysis and spondylolisthesis and stress fractures, and and the vast majority of these things, there's about 5 or 6 sources of pain that produce 95% of all the back pains. The other 5% are the cancers and the infections and all those
Yes.
red
All the
flags.
red
Yeah.
flags.
So 95% are things that we know about. We know actually cause back pain and back-related pain. Okay, so the question is, so what is the cause of these things producing nociception? All right, so we know that discs can be painful, but why are they painful? Now, we now know that actually that people who have pain coming from the anterior column, that's the vertebral body, the end plate, and the disc, probably
Mm-hmm.
constitutes 50 to 60% of all back pains. All right.
Yeah.
But we know that it's not just one single pathology. We now know from my own research that a substantial proportion of those patients show directional preference, and the symptoms can be made to centralize. So I call that mechanical discogenic pain. And I have my reasons for that, which we won't go into because it doesn't matter right here. But I call it mechanical discogenic pain because it behaves in a mechanical way and it follows the same patterns that McKenzie has talked about all these years. All right. But if you
Mm-hmm.
move them in one direction, they get worse and worse and worse, and their symptoms can peripheralize. And you move in the opposite
Yeah.
direction, and the pain goes the opposite direction. It gets better and centralizes. And
Yeah. Mm-hmm.
the only thing that I have added to McKenzie's original idea is that I now, to classify a person as being a centralizer or a directional preference, is that it has to be reversible and repeatable. In other words, you have to be able to take the pain away, bring it back, take it away, and bring it back like a yo-yo. If it's
I
truly
see.
reversible and repeatable, that is mechanical discogenic pain, and you know exactly what to do with it. You know what makes the pain come
Mm-hmm.
on. You can teach the patient, this brings your pain on, this takes your pain away. This brings your pain on, this takes the pain away. Don't do that, do lots of this. It's really simple.
Yeah.
Okay.
Mm-hmm.
That's basic
Understand.
McKenzie. And it doesn't matter whether it's flexion or extension or any combination of movements. All of those things, the McKenzie Institute people teach that perfectly. All
Yeah.
right. And so you don't need to learn that from me, although you can. All right. But the point is the McKenzie Institute people know, but that's what they do. And they're very good at it.
Yeah.
All right.
Mm-hmm.
So that's fine. Then you have the other people who don't centralize. Now, that's one of your questions in your list here. What do you do with people who
Mm-hmm.
don't have a directional preference? Now,
Yes.
that's all the rest of those backs. The people with facet joint pain, the people with sacroiliac joint pain, the people with stress fractures, the people with prolapse discs where there's extruded material pressing on the dura mater or the nerve root. All right. What do you do with those? Well, those are subsets. Now, here's something that will blow most people away. Did you know that there is no known conservative treatment that is successful for facet joint pain?
Did you know that there is no known treatment?
For confirmed facet joint pain. There's nothing in the
Wow.
literature. Do you know there's one randomized controlled trial of a conservative treatment versus another treatment on facet joint pain? One. And it's not controlled properly, it's not blinded, it's a lousy study. There are
How
no
come?
randomized controlled trials on patients with confirmed facet joint pain of any consequence. Zero.
How come?
Because they're not doing it. They're doing all these studies on non-specific back pain, not specific back pain.
Mhm. So,
No,
what do you mean by
I haven't
non-specific?
finished. Do you
Okay,
know
sorry. I'll let you
that
continue.
there are 0 studies on conservative treatments for proven sacroiliac joint pain? 0. None. There's no research. There's no evidence. So anybody who asks me the question, can you prove that having a diagnosis is effective? The answer is absolutely not. How can I? There's
Yeah.
never been any studies.
Mhm.
0 studies. Now, where's the future of research for back pain? The answer is let's start identifying patients
Yeah.
with known sources of pain and seeing what the subsets of those are. So, facet joint pain is not a single condition. You
Mhm.
can sprain that joint, it can become osteoarthritic, it may be subjected to some rheumatic condition. There are subsets of that subset. Now, there's no treatment to cover all of those things. You can't there's no good treatment, single treatment. There's only one single treatment that is effective for facet joint pain, and that is radiofrequency neurotomy. It does work.
All right.
It does work. And there is
Okay.
evidence to prove that. But all that does is it kills the nerves that supply the joint. It doesn't treat the problem.
For those of you who don't know, can you explain what is facetal pain?
Okay.
Because until I saw your video, I never heard about it. There's a proof.
Sorry. What are you asking? What's the question?
What is facetal pain? Can you define?
Facetogenic. The
Faceto
pain arising
facetogenic.
from the facet joint.
Facet joint.
That's the
Yeah.
lumbar
And
zygapophyseal joints. Yeah.
how is it? How do people perceive symptoms? Are they
They
located
have
in
back
one
pain.
specific area,
They have back pain.
like a normal back pain?
Well,
Yeah.
no, their back pain is usually unilateral.
Mm-hmm.
And it can refer
Yeah.
to the buttock, and it can sometimes cause symptoms in the leg, but mostly it's dominant back pain on one side.
Mm-hmm.
Okay, but the disc in the sacroiliac joint can do the same,
Yeah.
right? So
Mm-hmm.
the only way that you can confirm that a person has facet joint pain is by doing diagnostic blocks to the joint, and there is a well-established protocol to do that. And I work with doctors who do that here in New Zealand. And I've been working with doctors doing those things since the mid 1990s. All right. Now, so I can tell you as a manual therapist, a conservative therapist, all right, I'm not an interventionist. I'm a manipulative physiotherapist, a McKenzie practitioner. Okay. I can tell you that I have never successfully treated a patient with proven facet joint pain
Okay.
with manipulation, with mobilization, with exercise, posture instruction, acupuncture, or anything else. Never. Now,
Mm.
I have had some successes, but I cannot honestly say to you that it was what I did made the patient better.
I see.
And
Okay.
and I have to tell you, I feel the same way about sacroiliac joint pain too.
Mm-hmm.
So in other words, you have those are just two categories, subcategories of the non-specific back pain spectrum, where I believe that conservative treatment doesn't work.
So, just to summarize so that people can really understand, in the non specific lower back pain, we have different categories.
Mhm.
We have the facetogenic pain,
Yes,
sacroiliac joint pain,
yes,
discogenic pain,
yes. And vertebrogenic pain now, that's something that has emerged over the last 10 or 15 years.
vertebrogenic pain.
Vertebrogenic.
So, vertebrogenic, which is the most common of all these categories?
Well, when I teach that I don't talk about just discogenic pain anymore. Back when I did my PhD, that is all we thought was there. We thought that the disc was the cause of most of these pains coming from the anterior column. The anterior column
Mm-hmm.
is all of those structures anterior to the spinal canal. Yeah. And that
Yeah.
includes the vertebral body, the end plate, and the disc. Okay. Now, we were doing discography. We were injecting the discs to see if they caused pain with a negative control and all those things. If you read my papers, it's all there. But what we now realize is that when you pressurize the disc, it also distorts the end plate. So if you have pain coming from the end plate, which is a vertebral source of pain, then that is produced by discography as well. So we now know, with the work done by Hane, Albert, and colleagues on modic changes, that modic changes are the MRI evidence of end plate pathology. Now we also know that not all of those are symptomatic, but they can be symptomatic.
Mm-hmm.
All right, and so we now know that that if you have people with modic changes that are symptomatic, that it is the modic changes that are most likely the source of nociception. Or the modic changes are the changes you see on MRI. The pathology that produces the MRI image is what is producing the nociception.
Mm-hmm.
But that's not discogenic pain, that's vertebrogenic pain. All right.
Mm-hmm.
So
Coming from the vertebrae.
yeah, well, it's from the end plate and the vertebra. Yeah. Now there is a treatment for that. Now it's called vertebro-basilar nerve radiofrequency neurotomy ablation.
All right.
It's a relatively new thing. So the last 2 or 3 years. So we can.
So what does it do exactly?
Well, what they do is they drive a needle into the side of the vertebra, into the middle of the vertebral body, and then they do radio frequency neurotomy. They kill the nerves in the vertebra itself that supply the end plate and part of the disc. And so it's like doing radio frequency neurotomy to the facet joints, but it's done to the anterior column. And so that treatment is actually quite successful, and it actually does work. I have many issues with that treatment. As a conservative therapist, I don't think it is appropriate for a lot of people. All right. For example, for a person who's aged 20 years of age, you don't go ablating the nerves to that structure in a young person because you don't know what that's going to do 30 years down the track. But if you're a 50-year-old or a 60-year-old with chronic pain coming from there, then it might be a perfectly okay thing to do. So there are issues with that, but we now know that the vertebral body is a source of pain. We have known for many years that the disc is a source of pain since the 1950s, actually. All right, but we didn't know until the 2000s that the vertebral body was a significant source of pain as well. Now, those modic changes, we don't know, they're not all the same. All right. Some seem to be caused by an infection, and some don't seem to be an infection at all because they don't respond to antibiotics. Some do respond to antibiotics and some don't. So there are multiple causes of these pathologies which you see on MRI. So where does physiotherapy fit into all that? Well, in my opinion, physiotherapists are the best people to learn how to do the diagnostics. Not the interventions, not the injections, but the clinical workup.
Yeah.
We know how to move people around. We know how to physically examine people and say this person has directional preference. Conservative care is going to work for that person. The chances are very good. And if you mix that conservative, directionally specific treatment with rehab and graduated exposure to load and all those things that we know how to do better than anybody else, there's a group of people out there that we can identify, we put them over there. Then there's this group of people that we know physiotherapy does not work for. And we find out if they've got facet joint pain, and we can identify those people, I believe, with significant confidence. People with sacroiliac joint pain, people with vertebrogenic pain that is not directionally specific. Now, we can then be involved in the process of managing those patients. And that management could be by injection, by surgery, by cognitive behavioral therapy or functional therapy, by pain relieving techniques such as medications or acupuncture or whatever. But we're not attempting to treat the pathology because we know that there is no conservative care that actually works.
Mm-hmm. Yeah.
We may be involved in their care, but we're not the agent of change as such. It is the patient and often interventions that are going to work. That big group of people who are centralizers and have directional preference, we are the agent of change there. No question about that at all. Those patients whose pain can be made to centralize, we know what to do with those. We've known how to deal with this for 40 or 50 years now. All right. And we're good at this. We are really
Yeah.
good at it. All right.
Yeah.
But the other maybe 50% of back pains, all right, we will not be effective on. So we need,
Are you saying that is it, do you think that we can still test those patients, the non-specific lower back pain types of patients, by trying to centralize them at first because we don't have no
well,
other way to
one of your
diagnose?
questions is how long do you persist? How long do you,
Well,
yeah,
yes.
do you see the
When
patient
do we
every day
know? When do
forever?
we decide?
Or no?
Yes. Is it enough after first session after
No,
doing
no,
multiple
no, no, it's
repetitions?
not. No,
No.
the first session, you'll identify the easy centralizers, the people who clearly have a directional preference. You'll find that out in the first session with many people. All right. But then
Yeah.
as a group, a relatively small group, but a group who need a week or two of working hard to get that effect.
Hmm.
So depending on the individual factors, sometimes I'll see the patient on a daily basis. Sometimes I'll see them in 2 or 3 days after I first see them. Sometimes I'll see them a week later, but I will see them soon. All right, and
Yes.
I to make sure that they do not have a directional preference. If they do have a directional preference, then they get physiotherapy care, which will be in the standard McKenzie type of model. If they are non-centralizers, then we have to make a decision as to what the treatment will be. Are we going to send the
Hmm.
patient off for diagnostic investigations to find out where the source of nociception is? Or are we going to treat that patient functionally because it's minor symptoms? We don't want to do invasive things to these patients. If they have minor symptoms from the facet joint or the sacroiliac joint, we don't want to do injections. We don't want to do surgery. We don't want to do people who have minor symptoms. We don't want to do that to people with minor symptoms. So we manage those people from a cognitive functional therapy perspective, which I think is a very sensible thing. People
Hmm.
sometimes have to learn to live with some pain too, and we are good at this. Physiotherapists can be very good at this. A
Hmm.
mixture of medication and proper um, approach to pain works with these patients, I think, very well. And the
Hmm.
patients may not get a lot less pain, but they maintain their function, they maintain their mental health, and their involvement in life, and they can continue to look after their kids and be active and play sport and go to work and even though they have a bit of pain. That's not a problem. Pain is often something that people have to accept. And if you get to my age, if you haven't got pain, you're a rare beast. I have pain, but it doesn't stop me. Well, it does, but you know, I don't do as much as I used to do because I've got a stiff neck. I'm
Hmm.
getting old. So,
Hmm.
but I don't
Yeah.
I don't beat myself up because I've got a bit of neck pain.
Mm. Yeah.
All right. In other words,
It's part of getting
I've
old.
done cognitive functional therapy to myself.
Hmm. That's right.
I mean,
Yeah.
I've got facet joint pain at probably 2 levels of my neck. All right, and I could go and have radio frequency neurotomy to that, but it's not really necessary. It's not giving me constant headaches, and I'm not in pain all the time, and it's not it does sometimes disrupt my sleep, but not badly.
Yeah.
I live
Hmm.
fine. I don't need that other stuff. Occasionally, if I do something silly and I have a sore it's bad for several days, I take some anti-inflammatories for a few days, and it settles down. I'm fine again.
Mm-hmm. Mm-hmm.
It's these are okay. So in other words, physiotherapy isn't this or that, and that's it. The world isn't like that. Patients are not like that.
Yeah. Earlier you said, if I remember correctly and if I understood correctly, that there is no superior treatment in regards to treating lower back pain.
Non-specific low back pain. You got to be
Non-specific.
very clear
That's right.
about
Okay.
that. Some
Yes.
specific back pains we do have effective treatments for.
What are specific lower back pains then?
Mechanical discogenic pain. We can
Mechanical.
fix that.
Okay. So, for instance, the symptoms can be sciatica.
Well, if we can centralize it, yes.
Yes. Mm-hmm.
Okay. If
Mm-hmm.
you can't centralize it and you have a prolapsed disc, then there are specific treatments for that too, and they work very well. And I
Mm-hmm.
use epidural injections. I work with the surgeons. My conversion from to surgery is extremely accurate. I predict those patients who need surgery or who can manage without surgery very, very easily. That is a technology. When I give up, this next year or two, I'm going to be working on a group of people who have prolapsed discs that we've been working over the last 4 years or 5 years, where we've used injections a lot, called epidural injections, and appropriate care afterwards. There's a whole body of work there that I've never analysed, that I've got that I need to analyse and ultimately publish, I hope. But we now have a very good system. By the way, if you want to know about the system that I'm talking about for people with prolapsed discs, you read the work by Hans van Helvoort from the Netherlands. His work,
Okay.
he and we know each other very well. His work, do you know how to spell that?
No, but
Van
you can write it
Helvoort.
for.
It's spelled VAN
Yeah.
HEL
Mm-hmm.
VOIRT.
VOIRT.
Van Helvoort.
Okay.
Hans van Helvoort.
Yeah.
He's a McKenzie person. He's a McKenzie instructor, but he has worked very closely, as I have, with doctors and doctors who do the injections as well as the surgeons. And back in the late 1990s and early 2000s, we were having many discussions about what is the best mix of conservative injection and surgery treatments. And he's done the research.
Yeah.
He's published papers on it. And his model that he's published, we've been doing that. I've been doing it, the same model, as long as he has. And it works extremely well. And
Okay. I'll have a look.
no, it's
Yeah.
very
I'll write
important
down the
work. Very
reference.
important work. And he's literally next door to you people. He's just down the road. You should get
Down the road.
yeah. Well, for you,
Yeah, for you. Yeah, it's true.
not for me.
Just a short plane away.
Well, it's a short train ride for that matter.
Or train away.
Yeah,
Yeah,
that's right.
absolutely.
But no, Hans is a very good teacher, and he's done some very
Mhm.
valuable work there.
Mark, according to your experience, when are epidural injections have been the most effective when it came to
Okay.
treating specific
All
lower
right.
back pain?
My present practice is a mixture of chronic and acute. All right.
Okay.
I have a very close working relationship with the local emergency department here. And we have several of the physiotherapists who work in the emergency department who have been trained by me. And they analyze the patients in the way that I require. And those patients who are not admitted to hospital because of cauda equina syndrome or fracture or cancer or some other serious problem, they are discharged. They are often discharged to me and my team. And we see these patients in the community. Now, these patients will walk in the door on crutches, and in terrible agony. They are on morphine or on fentanyl, and I examine them, and If we cannot centralize the symptoms, if we are unable to get good control of their pain, we give them an epidural. Now, I have a very, very strict protocol that the patients must follow with the epidurals. And I accurately measure back, buttock, and lower extremity pain before the injection, then 1 hour, 2 hour, 4 hours, 6 hours after the injection. And then I see them a week later in the clinic and we do it again. And we can measure anesthetic and corticosteroid response using that methodology. And if they get a good result, we manage them conservatively. If we get a partial result, we give the patient, and they get an MRI first. They get an acute MRI within days to see if they've got a prolapse disc. And a few patients, I would say less than 10% of the patients that I send for MRI don't have a prolapse disc. My success rate, or my accuracy is better than 90%. Okay, so those patients with prolapse discs who get a partial result from the epidural, or they get a good result but the pain comes back after several weeks, right? Then we talk to the patient about whether they want to work on use natural history, because most of these patients will get better by themselves if we do nothing. Or do they want to go and have a conversation with a surgeon? And if they choose the surgeon, we send them off to an appropriate surgeon who then has a discussion with them about whether they should have the operation or not. If the patient chooses to have the operation, then I manage them through to 6 weeks after the surgery. If they don't have the operation, they choose not to have that, I manage them with natural history and medications and exercise and all those things. Now, these are non-centralizers, remember.
Yes.
These sciatica I can't centralize. We still manage them conservatively, but using natural history as our treatment, if you like. And so we use epidural injections a lot, and it is.
Do you do the injections yourself?
Oh no.
No. There's a doctor in the clinic.
CT or fluoroscopic guidance.
Yeah. Okay.
But I remember I'm practicing as a clinical specialist. And I've worked closely with these other specialists.
Yeah.
So they rely on me to do the clinical assessment and to analyze the patients properly so that they're not doing injections to people who don't need it. All right? So in other words, it's highly selected. In other words, I am treating a subgroup of sciaticas with injection. Not everybody with a sciatica.
Yeah.
It's very important to understand that the subgrouping thing is actually really important here.
I'm very impressed by your system in place.
It's very, very rigid. When I say rigid, it's rigid in the sense that my methodology is very precise. All right. But with the options available to patients range all the way from do nothing. If you have a mild bit of sciatica, bit of straight leg raise limitation, but you can't centralize it, I say to the patient, it's going to get better. Don't worry about it. We'll get you in the gym, get you exercising. You'll be fine. Get into it. If you have a lot of pain and you can't sleep and you can't walk, then we'll give you an injection. We give people choices. The patients make the choice. We give so the patient is fully informed about natural history, and they make choices. And we don't make the choices for them. They make the choices because we educate them.
Yes. And on that note, actually, Mark, my next question is, how do you manage a patient that doesn't want to do any exercise and that that the pain can centralize? How do you talk to them? How do you motivate them?
Well, you see, when you get to my age, you can look at the patient straight in the eye and say, do you prefer pain? I mean, seriously now, when you do this, the pain goes away. When you do that, the pain comes back. Now, I've told you to go away and do that which makes you better, and don't do the things that make you worse, and you're not doing it. Why? I look him straight in the eyes. Straight in the eyes.
Mm-hmm.
What is it? Do you like pain? You know? I've told you how to solve your problem, but you're not doing it. Why?
That's a good question. It would be hard to say
Well, no, but patients
something.
say, "Oh, I'm too busy," or this or that.
Yeah,
I said, "Look,
I don't
no,
have the
you
time.
came to me with a single. What you asked me to do was to help you with your pain. I've shown you how to help you with your pain. I can't do your exercises for you. I can't do the 600 or 1,000 backward bends that you need to do every bloody day. All right, not 1,000, not that many, but you know what I mean.
I
I
know what you
can't.
mean. Yeah,
You can lead a horse to water, but you cannot make it drink.
that's
All
true.
right, and so the important thing is that I've only got the reins here. But if you
Mm-hmm.
keep pulling on the reins, I'm going to let go
Mm-hmm. Yeah.
because you are here as a matter of choice, and so am I, by
Yeah.
the way, as the therapist. I don't have to see you. There's no moral or legal law that says that I must treat you even though you'll do nothing to help yourself. And I tell the patients that. I'm absolutely brutal with those patients. Brutal.
Yeah.
Because I do it in a nice way. You know, I mean,
Of
I
course.
don't beat them
Yeah.
around the head with it. You know, I just say, why? You know, if you want the pain,
Yeah.
fine. You don't need to see me.
Mm-hmm.
If you want me to magically pass, look, this I use J.K. Rowling stuff quite a bit. I say, you want magic? This is not Hogwarts. I don't do magic.
That's a good line. I like it. I might use it myself.
Well, it's not rocket science.
Yeah.
Every patient that comes to see me is a patient who has the right to choose, and they can choose the wrong things, and it is their choice. I'm a liberal. If you want to do
Mm-hmm.
things that are bad for your health, go for it. But don't ask me to solve your problem that you are creating yourself.
Yeah.
Before I taught you how to solve your problem, you didn't know what to do. Now you know. What you do with that knowledge is entirely over to you.
Yeah. Earlier, you were talking about chronic lower back pain. In what? How does it fall into the non-specific
Well, the
categories?
concept of chronicity, I don't personally like that word chronic. I prefer to use the word perpetual or persistent pain
Persistent. Yeah.
because
Mm.
chronic has this
Negative.
connotation
Yeah.
that it's impossible, that it's intractable. You can't get rid of it.
Hmm.
And
Yeah.
I've had patients. If you go onto my website, you'll see a patient called Ian who has had
Hmm.
8 years of daily pain. Every
Hmm.
day he had pain so severe it would bring him to his knees. It'd be like bang, and hit him like that, and oh shit, oh like this, absolutely
Hmm.
agony for about a minute. And he had chronic pain that would never go away. He was a man who as a job he was a traveling salesman, and he would travel the length and breadth of the South Island of New Zealand, and some of these drives might be 7 or 8 hours long, and to do his job, but he was unable to sit for longer than 1 hour. So every half an hour to an hour, he'd have to stop the car, get out, and lie on the ground.
Hmm.
Summer or winter, rain or hail, snow, somewhere he'd have to go and lie down every hour when he was traveling for 8 years. Now on my website, on my Facebook page, you'll see the initial an abbreviated vignette of
Yes.
his initial assessment, where he was shown to have an anterior derangement. For those people who are McKenzie trained, you know what I'm talking about. But for those people not McKenzie trained, he's a flexion responder. He has anterior column pain, which responds positively to flexion and gets worse with extension. And it's absolutely 100% reversible and repeatable in the clinic in the single first day. And he was essentially cured within a day. Yeah.
After 8 years, did you
After 8
say,
years.
of suffering?
Yes. Now, here's the thing. That's not to say he never got pain again. But
Yeah.
he was basically in control of his pain from the first day. And I've got a 5-year follow-up on him. And he is perfect. Now,
Amazing.
does he have chronic pain? Does he have chronic pain?
No.
No. Did he have chronic pain when I first saw him?
No.
No. He had persistent pain.
Yeah.
Mechanically persistent pain, because the mechanics of what he was doing with his body was persisting his pain. Once he changed his mechanics,
That's right. Yeah.
the pain stopped. Virtually stopped. Within a week or 10 days, he was essentially pain-free. But he was in control of his pain from the first day. Now, do you give that guy cognitive functional therapy? Do you go and give him pills? Do you give him surgery? Now, if he had had an anterior interbody fusion, that would have solved his pain. But all he had to do was a few flexion exercises. Why give him surgery?
And then slowly you introduced him back to extension.
Well, no, he never. I never did any extension with him. Didn't have to.
Didn't have to.
Don't do any more than you have to.
Mm-hmm.
But some people have. That's an anterior derangement. The posterior derangements, people get enough flexion in their lifestyle. They don't have to be given flexion a lot of the time. All right. What you have to do is make sure you don't give them so much extension and so make them so crazy about flexion that they don't ever flex again. That's a problem too. That's an iatrogenic cause of pain. That is. All right. But so you just treat that individual for who that person is. Some people listen to you so seriously, they take every word you say as gospel. And you say on the first day, you must not slouch and you must not do bend forward and you mustn't do this and what have you. And you do these exercises, and 10 years later, they haven't bent forward in 10 years. Well,
that's not good.
No. Have you ever tried to have sex without flexion? Not possible. You see what I'm saying?
Yeah.
So, living requires flexion. So the important thing is we want to get the patients back to normal life.
Yeah.
All right. You try putting on your socks without flexion. Very difficult. But I have had patients who have had somebody put on their socks for 10 years because some McKenzie practitioner said to them, "Don't ever bend." But that's what the physiotherapist said on the first day, and never said, "Now it's time to flex again." So, and you have to understand that person, that McKenzie practitioner, was not practicing McKenzie. McKenzie's system was very, very clear. After a period of avoiding flexion, all right, then you reintroduce it to remodel the structures and get the function back, right? It's very clear in his first textbook, 1981. He was very clear about that. So McKenzie is just not doing push-ups. It's a much more sophisticated system than that. Simple in principle, but not simplistic. I don't know whether there is a French translation for that, but it is not simplistic, but it is simple. Do you understand the difference?
Yeah, yeah, yeah. I don't know if there's a word
Simplistic
for
simplistic
simplistic.
means like it's you reduce it down to such a simple level that it loses meaning.
Mm.
Whereas if it's simple in principle, but the principle then expands out to deal with a vast array of different options.
Yeah.
Principle is simple.
Mm-hmm.
The system itself is not simplistic or not simple because it's complex because everybody's different, right?
Yeah.
So that's what I mean. In English,
Mm-hmm. Right.
there is clear concepts difference between simple and simplistic. I don't know whether that translates well, but yeah.
I will have a look at the translation. The English language is a very rich
Well,
language.
it is, but so
Uh,
is French too.
Lots of
And
words.
French and
Oh
German are
yes,
both
yes.
very rich languages, as indeed Chinese,
Mm.
by the way.
What did you say?
Chinese
The
is
word?
also very rich like that.
Oh yeah, yeah, yeah.
Yeah.
Hmm.
Did you know that the
Um,
original Oxford Dictionary, which was published,
yeah.
the original Oxford Dictionary was published in 1928, and they had 440,000 words.
Mm-hmm.
The Maori language, which is the local indigenous people's language here, their language had 800 words.
Wow.
Swedish might have 2 or 3 thousand words.
Really?
Yeah, not many. So those languages, like French, like German, like Chinese, like
Mm-hmm.
English, Portuguese too, I would think, those they have actively sought to create their own language words for modern concepts. I
Mm-hmm.
think the French also have an official organization for new words, right?
Yeah.
Yeah.
Mm-hmm.
Well, English doesn't need that, but the French have done that, and I don't know whether the Germans do the same. But for example, I had one of my business partners used to be is a German, and he told me that the German word for uh, a jack for when you're lifting up your motor car. We in English we call it a jack, right?
Yeah.
In German, it's a car lifter, but it becomes a single word. So in other
Mm-hmm.
words, they have used modern concepts. There is a German word, there's a French word, like the
Mm-hmm.
telephone became la téléphonique, right?
Mm-hmm.
So
Mm-hmm.
when the telephone was invented, they had to have a French word for it, and that's the way it should be. That's what the growth in the language should be.
Yeah. That's true. Very true. Yeah.
Anyway, that's what other questions? Go ahead.
Oh well, don't worry. Not too long now because we're already hitting
I know,
an hour and a half. But
but you can
um,
edit.
yes, I don't want to keep you too long though.
It's all
But
right.
um,
It's a daytime for me. It's like nighttime for you.
it's good. It's good. You don't count the time when you. It's so interesting. But my next question was: we're talking about McKenzie. Are there any limits in your view to the McKenzie method? And
Absolutely.
if so, what are they? Yeah.
Well, McKenzie was probably the first major thinker to say what the limitations for his system was. He was very clear. He never ever said that you can treat all backs with his method. He never said
Hmm.
that. He said, on the contrary, he said these are the patients that respond well and fast, derangement syndrome. These are the patients who may respond over time. They're called dysfunction syndrome to directional
Hmm.
loading. Okay. And anybody who's practiced McKenzie for any length of time will know that there is a proportion of those dysfunction patients who actually ultimately get worse if you continue. And these are facet joint pains usually. And sacroiliac joint pains.
Hmm.
They get worse. They appear to have a dysfunction, but they don't have a dysfunction. They have a pathology that causes limitation of motion at end range. And if you try to remodel it carefully over time, but it doesn't work. And McKenzie
Hmm.
knew this, and he had no problems with it. Then there's and imposter syndrome. We now know that imposter syndrome affects a fairly small proportion of patients, not very, but most of these patients have significant psychosocial issues. They're often, if I with all of my new patients, they complete the central sensitization inventory questionnaire, and I don't know whether you're familiar with that. Are you familiar
The
with
questionnaire.
the central sensitization inventory questionnaire?
It rings a bell.
Yeah,
Yeah.
it's a
It,
relatively new questionnaire. It was published first in 2012, and I've been using
uh-huh.
it ever since. And you can identify those patients who are sensitized. Okay, and I also use another questionnaire, the DAS-21 questionnaire, which gives me measures of depression, anxiety, and stress.
I will write them down and put them on the description of the
The
episode.
central sensitization inventory. I can send you the papers; it's not a problem. And
Yes,
also
please.
the
Yeah.
DAS-21 questionnaire, which I use as well.
Okay.
And
Do you use those for specific patients where you
no,
think there
every patient,
may be
every
some
patient.
every patient?
Yeah,
Okay.
I mean, you got to
Mhm.
remember, I'm practicing as a specialist here. All
Yes.
right, that's
Yeah.
where I need measures of psychosocial distress and sensitization, and those are
Mhm.
my measures that I use. I also use the Roland Morris questionnaire. Everybody uses
Mm.
or the neck disability index for the neck. Um,
Mhm.
I have a measure of disability, a measure of sensitization, and a measure for anxiety, depression, and stress. All right, and
Mhm.
every patient I see has that. But again, you remember that I have to be aware of those aspects of things more than most because of my role
Yes.
as a,
As a
as a clinical
specialist.
specialist.
Yeah.
Yeah. So,
Absolutely. Yeah.
but the patients with posture syndrome almost invariably are sensitized.
Mhm.
So, in other words, what that means in very simple language is that their nervous system somehow is over-reporting input.
Yeah.
In other
Yeah.
words, and you look at the pain drawing, I do pain drawings with every patient, and they have pain
Mhm.
everywhere, widespread pain. And they have trigger points in all these different
Okay.
spots and these sorts of things. And what it means is that the normal input the brain is getting from the body when you move your arms, when you move your body, all right, the brain has to make sense of this. And
Yeah.
normally, what happens, and I use this as an explanation for patients, is that take for example, I'll put my finger on their forearm like this, right? Little mark. These are age spots, getting old. If I press on that, that doesn't hurt me, does it? But if I increase the intensity of the stimulus at a certain point, my brain says, "Stop doing that. You're going to damage the
Mhm.
tissues," and that's
Mhm.
called
Yeah.
pain. All
Yep.
right. So, in other words, there's a threshold that your nervous system and brain chooses to report as a noxious stimulation, not just a stimulation, but a noxious stimulation, nociception. All right. So it's a threshold thing. Now, if you have a low threshold, then normal pressures hurt, normal stresses hurt. I do that, oh, it
Yeah.
hurts. But to you, a normal person, it doesn't hurt. But the very same
Mhm.
thing, full movement, but it hurts. Why? Because the nociceptor, the brain is saying that anything above that threshold is noxious, therefore damaging. So
Mhm.
these people
Yep.
are sensitized. In other words, so when they sit for long periods, the stress that you feel in your back after you're sitting for a long period becomes a pain. It becomes a pain in the neck. And that's why they have pain in the neck, the thoracic spine, and the lumbar spine so often. Yeah. And so these posture syndrome patients very often are highly sensitized and they have psychosocial issues that will need to be dealt with as well as posture instruction.
Oh, because I did the McKenzie training, and I remember that we talked about Buster syndrome, of course, and we were talking about young
Mm,
people who had
yeah.
it quite a lot because of posture, like watching TV, playing video
Well,
games.
that's the mechanical explanation, which is
Yes.
McKenzie's contribution. But there's more to it than that. With most of those people, you'll find that you will be able to lead them the horse to water, but you won't be able to make it drink. Why are you sitting on your telephone doing this for hours and hours and hours and hours, and
Mhm.
watching all these catastrophic gothic bloody images and stuff like that, and you're being bullied by people online, and there's psychosocial shit going on,
Mm.
that McKenzie really wasn't aware of.
Mm.
All he knew
Yeah.
was is that the pain was there after prolonged sitting.
Yeah.
And you've got to remember that he was making these categorizations in the 1960s and 70s.
It was a different world then.
Totally different world.
Mm.
People weren't sitting. I mean, school kids were doing more sitting than most people because they were at school.
Yeah.
And a studious, introverted patient was studying, reading for hours and hours and hours, and being at school and being a studious, very, very um, um, active student, and sitting and sitting and sitting, and had pain at the end of the day, and better in the morning, and better when I'm walking, but when I sit and study at night, I really get sore neck and sore back, and right. And these patients were often introverted teenagers.
Mhm. Mhm.
They weren't
Yeah.
out there playing sport and running around the streets being normal kids. They were sitting
Mm.
inside watching a bit of TV and reading books and studying.
Mhm.
Now, in the modern world, it's even much worse than that now.
Mhm.
What proportion of children are obese now because they don't do
Mhm.
any exercise at all?
Yeah.
We're seeing. I mean, um, when I was at school, the number of obese children was very small. Less than 10%, maybe 5% of kids you'd say are a bit overweight, and some were really obese, but very few. And they were treated very badly, by the way, because they were so different from the rest of us.
Yeah.
I mean, when I was in my teens, you know, that's that like that. You see that on there? That was on my belly. You could do that. I had no body fat at all. We were exercising all the time.
Mhm. Yeah.
Now, obesity is like 50% of the population. It's a different world,
Mhm.
you know. And so you have to view the McKenzie concept in a new light. It's still relevant,
Yes. Yeah.
but it has to be modified. It has to be, well, not modified, expanded
Yeah.
with our understanding of pathology, with our diagnostics, with the psychosocial stuff that we now are very familiar with, and all that. It's not it's what he did was pure genius in my opinion.
Mhm.
But we have to not just move on; we have to grow. Grow is the right
Mhm.
word.
Yeah. Mm.
Mm.
Agree. When you do the first assessment, how long do you take for the first patient?
45 to
Is
60
it
minutes
enough?
for me.
Okay.
And the patient has already done 20 minutes of questionnaires online before they even see me. And you've got
Oh,
to
okay. That's
remember,
very very well organized.
well,
Yeah.
yes, I have a system whereby um, the patient is given an appointment, and they must do their questionnaires online before I see them. And if they are people who are not comfortable with doing stuff online, then I will bring them in an hour earlier or half an hour before the appointment, and the receptionist will get them to sit down at the computer to do them, and I will help them through them. Some
Mhm.
people, like maybe one out of every 300 or 400 people, just can't do them. They can't read or something like that. But
Mhm.
that's okay. But the vast majority of people do my online material. All those McKenzie questions: what makes you worse? What makes you better? That's all done with questionnaires. So I spend that first half hour exploring the patient. So my history taking
Mhm.
is very precise,
Yeah.
very full, and most physiotherapists don't have the time to do this. By the way,
I know.
but I'm practicing as a specialist now.
Yeah.
And so as a consequence, I have to know all those things. I have to know what drugs they're taking. I have to know what treatments they've had. I have to know, what's been tried, what has failed. Most of the patients that come to see me have already been seen by competent physiotherapists. And they've been sent to me by physiotherapists. I mean, I still see patients from doctors and surgeons who don't know what to do, all right, and have not done anything with these patients. But I say 70 or 80% of the patients that I see come from physiotherapists who are competent, good people, and the patients are not getting better and they want advice. So I need to spend that time.
Yeah. So before they come in, you've already read all the answers from the questionnaire, so you already know a lot
And
about
I have
them. Yeah.
I have a very good profile. And they, of course,
Mm.
they come in quarter of an hour before the appointment and do a pain drawing as well. I place a lot of emphasis on the pain drawing. They must do I use colours, and people who do my
Yes.
courses will see my coloured pain drawings. They are very helpful.
Mm.
So I know where.
And do you show? Sorry.
Go ahead.
Go on. Do you show them at the end of the treatment? Do you show them the color? And then you ask them to do it again
No,
and
I
see the
don't
difference?
actually. I don't do
No.
that, although that is certainly an option. If the pain is centralized, then you could do another pain drawing to demonstrate that. But I don't do that. Most of my patients have already had that attempt to centralize it. So
Hmm.
the number
Yeah.
of patients whose symptoms centralize in my clinic is very low because they've already been seen by competent therapists. I'm seeing a selected group of non-centralizers mostly.
I see. Hmm. I see.
Mm.
Yeah, it's interesting. Yeah, and do you videotape your
Every
patients? Is it every patient?
Yeah.
So you don't take notes during the
No,
assessment. Yeah, you just like face to
face to
face
face.
ask your questions.
Me and
That's
you,
great.
me and you. Tell me a story. And I
Mm.
structure it. It's a structured interview. It's not random. The patient wandering all over the place. I say, where is your pain? I check the pain drawing to make sure they got the left and right correct, and where the dominant pain is, and where the pain started. Then I get the patients get that scanned in. I come back and I see the patient. I say, now, okay, tell me, when did this all start? How long ago? And if they start rambling off onto something, it hurts me when I'm sitting. No, no, no. Now, answer my question, please. What were you doing at the time the pain commenced, and how long ago was that? Well, this started last week. Yes. Did you have pain before last week? Oh, yes, I've had pain for years. Okay. How old were you when you first started to get pain? So in other words, I want to know what the story is,
Mm.
what the episodic or whatever history there is, and then what is the most recent event that led them to come to see me, etc. So I lead them. I structure it, but I will not allow them to miss my questions.
Hmm.
I
Yeah.
must get answers to my questions. It's got to be their answers, not my answers. It's got to be their answers, but I must get answers. And so I'm very,
Hmm.
very demanding of my patients in terms of the history. And I make no bones about. I don't. I'm not gentle in some respects because, for example, if I suspect a patient is a drug user, for example, or and if I'm looking at them and they're telling me that they have lost a lot of weight in the last 6 months, I'll say, really, why? Was that intentional, or you don't know why?
Hmm.
I mean, are you otherwise well? I mean, so in other words, they lead me, but I must get answers, and it can take a while.
Hmm.
And then my physical examination can take 15 minutes most of the time, maybe 20. If they're a patient that needs a lot of, like an acute patient that's very difficult to move, the history generally is really shorter, all right, because they're in acute pain. And then the physical examination to see if I can centralize the symptoms is much longer because they're in a lot of pain. So it varies, but the chronic pain patient, a lot of it's history, mostly, and then there's the physical examination, which may usually take 15, maximum 20 minutes.
Mm-hmm. Do you give them the exercises to go home
Yeah.
on the first
Oh yeah.
session? Yeah.
But sometimes if I cannot complete my appointment and the time, I bring them back as soon as I can the next day if necessary to complete my examination, or the next week. Sometimes I don't have time. The story's so long that I don't have time to do the repeated movement assessment. I bring them back the next week and I do their repeated movements assessment then.
Mm.
So, but it's important that I get the story right.
Yeah, absolutely. Yeah. Mm-hmm.
Yeah.
Wow. I have one last question, Mark, and then I will let you go. But thank you so much. It's a very simple question, not simplistic, simple. Um, what makes a good physio
Hmm.
in one sentence?
Oh. I won't make it in one sentence, but I'll give you some of my thoughts on that. First of all, we're all different.
Yes.
I have physiotherapists who are not like me at all, but they're just as good as I am. They are much more empathetic than I am. They're much more caring and less brutal than I am. I mean, I'm a personality of a certain type, okay, and so patients work with me, and I'm trying to be as gentle as I can, but I must get answers. All right, that's the person I am. But not all physiotherapists are like that. So in other words, what I really want from a physiotherapist is you must be a seeker of truth. How you get to that point is unique to you as a physiotherapist. You have to have certain basic trainings, all right, in terms of your history taking and assessments and what have you. If you want to do back pain, you have to certain things you must know how to do, all right, and how to interpret the information, all right. But that's just training. But what makes a good physiotherapist is somebody who's a seeker of truth and who genuinely wants to be an agent by which that patient gets the best result their body will allow.
Hmm. Very well said. I like it.
Mm. It's not an easy question to answer because there are many physiotherapists, very different people who are outstanding, and there are very good
Yeah.
people who are very competent, but they're not good physiotherapists.
Mm-hmm.
They know a
Well,
lot of stuff, but they're not good physiotherapists.
yeah. And the same goes for patients as well. You know, we say uh, the physios have the patients they deserve. You know, some patients will go to.
Well, so I remember McKenzie. I asked some of these questions to McKenzie years and years ago, and he looked me straight in the eye and he says, "Mark, you can't treat idiots." And it's true. Some patients, just you have to say, "I can't help you," because you
Mm.
can't. They're not ready for help. I'll give you an example of one case. One case before we
Go
go.
on.
This is a
Yeah.
man who. This was back in the early '80s when we were just learning about the gate theory of pain. All right, Melzack and Wall, the puzzle of pain, all that stuff. This is the early days of our understanding of the whole complexity of pain. And this guy was sensitized, what I now know to be sensitized, distressed, all that stuff. He was overweight and he was angry and he was all these things. And he had this pain and he didn't centralize and his symptoms were bad and it was disabling him and all that. And I tried to start to explain to him about how pain is a complex phenomenon. And I started going into some explanation. And again, probably I was not that good at it at that time, but I was doing the best I could do. And he got angry with me. He says, "You are saying it's all in my mind?" I said, "No, I'm not saying that at all. In fact, I'm saying exactly the opposite." All right. And he got angry and he walked out on me. Okay. So, okay. 5 years later, the same guy comes back into the clinic with a similar problem, but only local back pain this time. He says, first of all, I want to apologize. I said, oh, okay. And he said to me, Mark, he says, I apologize because I behaved inappropriately. And I think I'm ready to listen to you.
Well done.
And he got better.
Amazing.
Yeah.
It just took him 5 years to come
Yeah.
around, but he
And
did it.
he was that's a person of extraordinary courage, by the way.
Yes, absolutely. Yeah.
So that's a real case. I don't remember his
Mhm.
name. I don't remember any other details other than that. But that was one that stuck in my mind. Is that some patients,
Mhm.
and sometimes they've got to be ready. It's what is it?
Yeah.
What was it? It's something that's about teaching. There's several things about when the student is ready, the teacher will appear.
Mhm.
Well, it works the other way too.
Yeah.
When the when the teacher is ready, the students are already there.
Ah, yes.
Works
Oh,
both
I
ways.
forgot. But
Same with
yeah.
patients.
Yeah, yeah, yeah.
Sometimes
Yep.
sometimes the patient knows more about what to do than you do, and you have to be
Yeah.
prepared to listen. Most of the
Absolutely. Yeah.
time, it's the other way around, though, where the
Yeah.
patient has to be ready to listen to you and to be
Mhm.
guided by you and to be given the information from you. Right. So
Mhm.
this is this therapeutic alliance, this rapport with the patient that we have to have,
Mhm.
and that takes years to develop as a physiotherapist or any clinician for that matter. You don't have to be a physiotherapist, obviously, and
Yeah.
and it takes years to develop. And some people never get it. Some people are naturals. I don't think I was probably a natural at this. This was an educated development in me personally. I was always
Mhm.
interested in the patients, which probably is probably the big start. And I
Mhm.
was always honest
Yeah.
about my successes and failures. All right, I think that's really important to be. You have to be honest about when you're succeeding and when you're failing. And you have to accept the fact that you can't win with everybody.
Absolutely. Yeah.
Yeah.
Well, that's what constitutes a good therapist.
Well, that's your description now. It's
That's right.
fine. All right, man.
Well, thank you so much, Mark. I really, really enjoyed it. Thank you for your time. That was super interesting. And yeah, wish you best of luck then for
And,
your
we'll-
for your
and
trips this
hopefully,
year.
maybe I'll see you when I'm in Paris. Maybe we can have dinner or something
Yeah,
like that.
that would be really nice. Absolutely.
Okay.
Yeah, we'll go for a beer. Bye, Mark. Have a good day.
Goodbye.